Welcome back to Corium. I'm Brian Gilberti, and today we're joined by Dr. Avir Mitra. Dr. Mitra recently joined our team from Sinai and is an associate professor in emergency medicine, as well as being a seasoned podcaster with multiple cameos on Radiolab. We're really excited to have you as part of the team here at NYU and in the studio with us, Avir.
Thank you for having me.
Today we're going to cover immune checkpoint inhibitor toxicity, and we try to keep it core on this podcast, and today I think we're going to do just that, but there's going to be a lot of nerding out in this episode just to be upfront. And Avir, I have to be honest with you, this was not a topic that was covered in Tintinelli's last time I read it, but it's something that we should all keep in mind, and we'll get to why that is in a bit. But set the stage for us. Tell us why these medications are so important for us to know about.
Yeah, well, I'll just start with a hot take. I think in 20 years, this will be in Tintinelli, so it's time for us to get ahead of the curve. And what I want to talk about today are immune checkpoint inhibitors. And these are drugs that were released first in 2011 and now have over 83 indications in oncology, over 17 different cancers, and about 250,000 people are using them. So this is huge. It's a revolution in the world of oncology, and it's really on us to know what's going on with these drugs because we are seeing them and we're going to be seeing them a lot more.
Okay, perfect. So these are new medications that are really changing the landscape for treatment of certain cancers. And some examples of the most common ICIs would be pembrolizumab, also known as Keytruda, and Opdivo, also known as nivolumab, just to name a few. Now, tell us about how they work.
Okay, yeah. So just to take a step back, right? We're increasingly recognizing that cancer is in many ways an immune issue, right? Because every day our T cells are recognizing potential cancer cells and killing them. So it's only when cancer cells learn how to evade the immune system that they manifest as true cancer. So with that understanding, these drugs have been developed to basically rev up the immune system. So what I mean by that is if you're a T cell, you have different receptors. Some receptors essentially upregulate you, tell you to proliferate, tell other people in the immune system and start fighting, and other receptors you have don't let you proliferate. So cancer cells that become successful are able to downregulate the T cells. They bind to T cells and downregulate those T cells. Immune checkpoint inhibitors essentially are small molecules that interfere with that binding. So they either bind to the receptor or they bind to the ligand and prevent the downregulation. So they unblock the block, if that makes sense, and essentially upregulate the T cells. The T cells all of a sudden are able to recognize the cancer, communicate about the cancer, and fight the cancer.
Okay, interesting. So this is a common tactic used by cancer cells, and this medication is going to take that away. And in a way, the cancer cells say, okay, well, they sense that they're going to be detected by the immune system, say, okay, look, nothing to see here, move on. And in that way, they're able to proliferate. But these medications take that tactic away. Now, moving on in broad terms, why do these medications pose risks?
Right. So what these drugs are doing is essentially revving up the immune system, specifically T cells. That's great because you want them to fight cancer. But the downside is those cells can start to fight your own healthy cells as well. So what you can present with is what's called immune-related adverse effects, but what I like to call the itises, basically autoimmune attacks to any organ system. But the common ones are colitis, pneumonitis, dermatitis, hepatitis, and then endocrine issues, of which the common ones are hypothyroid, hypocortisolemia, and hypophysitis.
So this really gets to a central tenet in medicine that there is no such thing as a free lunch in medicine. Every medication has a side effect, and these meds certainly are no exception. Now, in the ER, we're often the first to encounter these adverse effects. So let's start with pneumonitis, for example, which can be particularly tricky to diagnose. What should we ER physicians be on the lookout for? And while you're talking about it, what is the typical timeline for developing pneumonitis when you're on these medications?
The good thing is the timeline for these side effects is the same across, no matter which organ system it affects. And these side effects can start literally after the first dose or as late as 2 years after you stop the medication.
Wow.
Because you got to remember, these drugs aren't just like having a direct effect. They're essentially training your immune system. So the side effect profile is kind of crazy in that way.
Okay, so let's say you have a patient in whom you're suspecting pneumonitis. Walk us through your workup for this patient. What are you ordering?
Yeah, so these patients are going to present like they have a pneumonia. So they're going to have a cough. They may have a fever. And you're probably going to start with an x-ray, which may see consolidation like a pneumonia. So it could be unilateral, it could be bilateral, it could be fluffy, it could be anything. And so at that point, it may be a little confusing because chest x-ray isn't the best imaging modality. We miss a lot of stuff on chest x-ray. So if you're suspicious for a pneumonitis, you may want to get a CT where you'd see ground glass opacities. You may see more infiltrates, and that would raise your suspicion.
Okay, good. And also your CT can be useful because our differential in these patients can be broad. These are very complex cases, and it could be something other than pneumonitis. It could be malignancy-associated pleural effusion, or in certain situations, if the clinical picture fits, it could be an acute PE. So a CT with or without contrast can be a useful test here instead of just jumping to empiric therapy. But each case is going to be different.
Right, exactly.
And now going back to what you said, because it's an essential point that you made, that there's no fit timeline for this. It could be a few weeks after starting the medication. It could be even a few years before a patient develops these side effects. So we have to always keep this on our differential if the symptoms and the signs fit, that the patient may be having an immune-related adverse event. Okay, so now we've covered pneumonitis. Let's discuss some other common serious toxicities related to ICIs. What about colitis? Anything unique about this presentation?
Not really. Your colitis is going to present like any colitis that we see in the emergency department. Patients are going to have diarrhea, watery stools. They may have low-grade temperatures or fevers. And if you get a CT, you will see fat stranding and inflammation around the colon. So you won't be able to tell if this is an infectious colitis, if they have C. diff, versus if this is a autoimmune colitis.
I see. Okay, so now we've covered pneumonitis and colitis. Now let's move on to another significant implication of this medication that could be a bit more subtle than the others, which is endocrinopathies. Tell us about what we know about these side effects.
Right. These ones are a bit more challenging, so I think it's more important to have a high degree of suspicion to keep this in the back of your mind. But they can present as hypothyroidism, so almost like a Hashimoto's picture. So, if you sent a TSH, it'll be high, but people will be presenting with fatigue and all the normal low thyroid things that we've learned over the years. The second one is hypocortisolemia. So these patients are going to present with a low blood pressure that's not really responding to fluids. They're going to be fatigued. On a BMP, you may find that their sodium is low and their potassium is high, similar to any hypercortisol presentation we've ever seen before. And then the last one is hypophysitis, which is essentially just pituitary dysfunction at a grand scale. So this is going to be headaches, nausea, fatigue, and if you send labs, their pituitary function will be low across the board. They also may present with a central diabetes insipidus type of picture. So, not something that would be very easy to nail the diagnosis in the emergency department. But again, I think it's important that we just keep this in the back of our minds as part of the differential. And when we talk about treatment, it'll make sense why I'm sort of saying this.
Okay, so let's do just that. Let's talk about the management for these patients. Let's say we've already pinned down the diagnosis of pneumonitis, for example. What are the next steps for us?
So it turns out to be pretty simple. The management for immune-related adverse effects is a drug we already love, prednisone. And it's going to be 1 milligram per kilogram daily. Simple as that. So when we're in the emergency department, when you're working these patients up, you are probably not going to know for sure in the immediate craziness of the ER whether this is an infectious process or an adverse effect to their immune checkpoint inhibitor. And I've spoken to a bunch of oncologists about this, and the best course of action is to start your antibiotics like you normally would for any oncologic patient. But in addition, you'd want to start steroids. You'd want to start the prednisone and hold their immune checkpoint inhibitor until they speak to their oncologist. And that way you're covering your bases on both sides.
Mm-hmm. And this is another important point, that there is going to be some fog in the ED when it comes to diagnosing this. And it's going to be impossible to tell if a patient has increased inflammation from the medication, a bacterial infection that would benefit from antibiotics, or both. And as a rule of thumb, the sicker and more complex a patient is, the less room for error we are going to have.
And, the oncologists I've spoken to have a very low threshold to start steroids, even if there is an infectious process.
Right.
They believe that the steroids are going to help them, even if they're suffering from some sort of infection. So a very low threshold to basically do what you'd normally do all your labs, do all your imaging, start all your antibiotics, but add prednisone on top.
Okay. So it's an and more than an or.
Correct.
And more than or when it comes to management. Okay. Now, can you wrap us up with some final tips for ER physicians when they come to managing this case? And then also talk about one of the more difficult questions that are to answer on podcast form, just because there's so many nuances, so many considerations with cases, which is disposition of these patients.
Yeah. So in terms of disposition, there's no hard and fast rule. If you're suspecting an immune checkpoint inhibitor adverse effect, it doesn't mean they have to be admitted for that. So you have to go based on your clinical gestalt. Like, is this a patient that looks sick enough to warrant admission? Then admit them. If they look fine, if they just have a dermatitis, for example, or hepatitis or something pretty mild, you can discharge them. But I think the biggest thing is to touch base with the consultant, touch base with oncology and let them know, hey, I'm suspecting this. I'm holding their immune checkpoint inhibitor. I'm starting steroids. I'm also starting antibiotics, and I would love for you to follow up with them either tomorrow or the day after when the dust is settled to figure out what's really going on here.
Right.
And I want to mention that, in the world of oncology, starting steroids and holding the immune checkpoint inhibitor when an adverse effect starts is considered an emergency. So this needs to be treated like an emergency for us because these patients are literally, in many cases, alive because of the immune checkpoint inhibitor. And if we start those steroids soon enough and hold the immune checkpoint inhibitor, there's a good chance that they could take a break from it and get back on it. But if we let these itises flare out of control, they may never be able to restart that immune checkpoint inhibitor. So it's very important that we recognize this, think about this, and play it safe.
Okay, very good. A lot of important considerations there. Let's go over some take-home points. ICIs are a new class of cancer drugs that release the brakes on the immune system, allowing it to target and destroy cancer cells more effectively. Unlike traditional chemotherapy, though, ICIs help the immune system develop memory and adapt to cancer, but since it modulates our immune system, there can be unique side effects when these medications are used. These are immune-related adverse events, which can take many different forms, with some examples being colitis, pneumonitis, dermatitis, and endocrinopathies. Some of these processes are going to share a lot of symptomatology with infections, and this is going to be one of the difficulties when diagnosing and managing patients on ICIs in the emergency department. But if you do suspect this, the cornerstone of managing a patient with an adverse event in the emergency setting is going to be the rapid administration of steroids like prednisone at 1 mg per kg and the temporary holding of the ICI. Starting steroids early not only controls the symptoms, but also improves the chances that the patient can safely resume ICI therapy. And finally, disposition is going to be a very complex decision that's going to involve multiple parties, including the patient, the oncologist, considerations of access to care, just to name a couple of considerations. Okay, that's going to do it for this episode. Avir, it's great to have you in the studio and a part of the team here at NYU.
This was fun. Thank you.